Welcome, medicos. Let's begin with this quote. Happiness is the highest level of success. Be happy, keep smiling. Today's topic is antibiotic associated diarrhea. In this, we'll be reading about Clostridioides difficile infection. So let us begin. So first of all, we'll talk why it is named so. It was named due to its unusual difficulties involved in isolation of this particular bacteria, and hence it was named as C. difficile. Clostridioides difficile is an obligate anaerobic bacteria. It is gram-positive and spore-forming bacillus. All of these three is important. And it causes pseudomembranous colitis. This appears as a 5 marker in university exams. And why does this happen? It happened due to prolonged antimicrobial uses. Now let us learn more about it. So let's talk about the pathogenesis. We'll discuss first about the risk factors. So first we have prolonged hospital stay. So hospital acquired illness. For example, as we read, it is a spore forming bacillus. So the spores are present everywhere and hence in the hospitals too. And then the bacteria get colonized in the colon of the patient. And also the most important risk factor is prolonged antimicrobial uses, prolonged antibiotic uses. What happened is this antimicrobial caused disruption of the normal colonic flora. And once normal colonic flora is disturbed, it enhances the susceptibility to C. difficile infection. Now, what are the antibiotics? The most common is associated with cephalosporin like ceftriaxone, others like clindamycin, ampicillin, fluoroquinolones like ciprofloxacin. Also, vancomycin and metronidazole, drug of choice in C. difficile infection. So, it is a drug of choice in C. difficile infection, but if it is also used for a prolonged duration, it can also carry a risk of C. difficile infection. So we should be very judicious when we are using antibiotics. Other risk factor like host immune response. How does the host response will determine the outcome of the infection? For example, if the person develops a strong IgG response to the toxin A, then the patient will become a asymptomatic carrier. But if the patient develops inadequate IgG response, the person will develop disease. Others like advanced age because of immune deficiency and all. Then suppression of the normal flora. How this happens? Normal flora helps in converting the primary bile salts to secondary bile salts, which in turn resist the germination of spores. But once the normal flora is disrupted, it will help in the infection. It will increase the susceptibility towards the infection. Then we have immunosuppression, cancer chemotherapy, gastric acid suppression medications, malignancy and GI surgeries, and use of electronic rectal thermometer. These are the risk factors for C. difficile infection. Now, before beginning with the pathogenesis, we'd like to say that C. difficile may be harbored as a commensal in our intestine. It can be as a commensal in intestine. However, only the toxigenic strains produces pseudomembranous colitis. And as it is written here, pathogenesis is toxin mediated. So C. difficile produced two powerful exotoxins, toxin A and toxin B. Toxin A is enterotoxin and toxin B is cytotoxin. Both of them are secreted in the intestine. Now this toxin, how does it act? It causes glycosylation of GTP binding protein. It glycosylates the GTP binding protein, which causes disruption of the cytoskeleton. And what is this GTP binding protein? GTP binding proteins regulate the cellular actin cytoskeleton. So once this happens, there is a disruption of the cytoskeleton, which causes loss of cell shape, loss of adherence, and disruption of epithelial cell barrier. These further leads to diarrhea and pseudomembrane formation. One important point here is infants do not develop symptomatic infection because they lack suitable mucosal toxin receptor, which usually develop later in life. However, asymptomatic carriage is documented. So infants lack mucosal toxin receptors, hence they will not develop symptomatic infection. Now we have something called hypervirulent epidemic strain. Recently this strain has been described. It is known as hypervirulent strain because it produces higher level of toxins which causes severe infection. And this particular infection, fidaxomicin, is the drug of choice. Fidaxomicin. Now let us talk about the clinical manifestation. Diarrhea being the most common cause. Anyway, the topic is only antibiotic associated diarrhea. And other symptoms like fever, abdominal pain, leukocytosis, and blood in stool is uncommon here. Then pseudomembrane formation. This pseudomembrane is composed of necrotic leukocytes, fibrin, mucus, and cellular debris. The size of the pseudomembrane ranges from 1 to 2 millimeter to large enough to spread over the entire colonic mucosa. So it can spread over the entire colonic mucosa. And this membrane attaches to the underlying mucosa and it appears as whitish yellow plaque. So this appears as whitish yellow plaques. Now the most important aspect of microbiology is laboratory diagnosis. So first of all, we discuss the case definition of C. difficile infection. When we say it is a C. difficile infection, it comprises of 3 or greater than 3 unformed stools per day and isolation of the bacilli followed by toxigenicity testing. We know that this C. difficile can harbor as a normal flora, normal colonic flora, but some of them are toxigenic. So we have to check the toxigenicity. Now the laboratory diagnosis, we have stool culture, cell culture, cytotoxin neutralization assay, antigen detection, toxin A and B, glutamate dehydrogenase, molecular methods, colonoscopy and histopathology. Let us see about each one of these. So stool culture. Stool culture should be done in anaerobic condition because it is an anaerobic bacteria at 37 degrees Celsius for 24 to 48 hours. Then it should be done in a specific selective media like CCFA and CCYA, which is cefoxitin cycloserine fructose sugar and cefoxitin cycloserine egg yolk sugar. So what is specific selective media? Specific selective means it will, in this media only C. difficile will grow and it will help us to identify it. This stool culture is highly sensitive and specific, but toxin demonstration is needed. Why? As I said, C. difficile can colonize the GIT. Only isolation will not be enough to establish the infection. We need toxin demonstration too. Now we have cell culture cytotoxin neutralization assay. This is highly specific but not as sensitive as stool culture. And it has long turnaround time also. Antigen detection. Rapid test or enzyme immunoassay is used which target the specific antigens in stool specimen. Then toxin A and B, toxigenic strain, to find the toxigenic strains. And then we have GDH, glutamate dehydrogenase. This glutamate dehydrogenase is present in both toxigenic and non-toxigenic strains. So detection of GDH. So we can, if we detect the GDH, but there is absence of toxin, this indicates presence of non-toxigenic of C. difficile in the specimen. What I mean to say, if we detect GDH, glutamate dehydrogenase, but toxin is not indicated, that means the strain is non-toxigenic. So molecular methods, we have polymerase chain reaction PCR, real-time PCR and gene expert. In this we are targeting the genes coding for C. difficile TCDA, that is toxin A, toxin B and triose phosphate isomerase in the stool. It is highly sensitive and specific too, with faster turnaround time. Then we have colonoscopy. It is highly specific, but the sensitivity is low. And we can see the pseudomembranes in the colon. Then we have histopathology. Histopathology of the colonic pseudomembrane, which we will obtain from colonoscopy. And then H&E staining is done. Treatment. So for treatment, we can give antimicrobial therapy. Some of the antibiotics, antimicrobials we can use. For example, if it is mild to moderate cases, in the initial episode, oral vancomycin or fidaxomicin is given. These are the drug of choice and it is given for 10 days. Oral metronidazole can also be given alternatively, but it is less effective. So mild to moderate cases, remember oral vancomycin. Oral is very important here. Oral vancomycin or fidaxomicin. Then in fulminant cases, oral vancomycin plus intravenous metronidazole plus rectal instillation of vancomycin is recommended. So oral vancomycin plus IV metronidazole plus rectal instillation of vancomycin is recommended in fulminant cases. For recurrent cases, the treatment options are: for first recurrence, oral vancomycin or fidaxomicin is given for 10 days. For recurrences, for multiple recurrences, taper and pulse regimen. That is, after the 10 days therapy of oral vancomycin, 125 milligram 4 times a day, the doses can be tapered over 2 to 8 weeks. So that is why it is known as taper and pulse regimen. So for first 10 days, we will be giving oral vancomycin 125 milligram 4 times a day, and then the dose will be tapered over 2 to 8 weeks. Other treatment modalities are IV immunoglobulin. So IV immunoglobulin, that means passively we are providing the antibodies to neutralize the toxins which is produced by C. difficile, and that primarily toxin A is neutralized. Then there is something called fecal microbiota transplant, FMT. What is it? This can be considered for multiple recurrent cases. It involves replenishing of the gut flora with donated feces from a screen healthy individual. So from a screen healthy donor, feces will be taken and it will be transplanted into the patient so that the gut flora will replenish. Then the drug which we read, fidaxomicin, it is a macrolide antibiotic and it can be used in initial and recurrent cases and also against hypervirulent stain, as we read earlier. Now there is a very important note. IV vancomycin is not effective for C. difficile infection. We use oral vancomycin and this can be a MCQ. Which of the following is not suitable in C. difficile infection? Oral vancomycin, fidaxomicin, IV vancomycin. The answer will be IV vancomycin. It is not effective for C. difficile infection. We'll get back to you soon. Let's end with this quote. Great things are ahead. You just have to believe and keep moving forward. Thank you.